they lost in court for kidnapping. You better make sure your refusal is
rock solid.
You are listening to EMS with your hosts Erik Axene and Matt Ball.
Yeah, I haven't had a lot, but I've had some patients that just absolutely refuse help. Do you get that much in the ER?
Oh, absolutely. Absolutely. I had a patient once that was brought in by law enforcement. He got pulled over and said, having chest pain. A lot of people do that to get the medical clearance to get out of being arrested, right?
Of course, yes.
As you know. But this guy was having a STEMI.
Legitimately.
Yeah.
Yeah, you can't take it for granted.
And you know what it was? It was elbow pain, actually. He's like, my arm is killing me.
Did you think he was faking it first?
I honestly did.
Okay,
that's fair. And I figured he's trying to get out of a ticket.
Yeah.
But I got the EKG showing a STEMI.
Okay.
And he absolutely refused care. He didn't want to be treated. Which in the context of what was going on was confusing to me. But I did convince him to get admitted. But he said, there's no way I'm going to the cath lab, but I'll be admitted. So I admitted him to our like a step down unit, PCU, and he never went to the cath lab. He was having a heart attack.
Just dealt with it.
And that's a hard part about these refusals, is that legally we cannot get in the way of the decision of a person with mental capacity and legal, capacity. Yep. We cannot, we can't get in their way.
Yeah, they have the right to refuse, even if it's going to mean bad stuff for their health. I've never had where I've been on a call. I mean, I've had patients certainly that were belligerent or maybe intoxicated or on some substance and uncooperative, where, I might have to call med control and get hey, or call the police department or whatever the case may be,
right, and
force them to get care because they didn't have capacity, right? But I've never had somebody that was I've had patients that were having strokes and STEMIs and stuff that were like, oh, no, I'm fine. But then when you educate them, like, no, bro, you're not fine.
Yeah.
What I'm saying is, this is what's going on. And usually, when you tell them, like, hey, this is what I see is going on or could be going on. There's a good probability of it.
But there's a process I had to go through to really legally allow them to refuse.
Same with us.
And that's what we're going to talk about today. Because there's nothing more concerning to us from a litigation standpoint than refusals. Absolutely. And I know in our department, about 1/3 of all the calls are refusals.
Yep.
And so we've got to be really good at this. Everybody watching this, I mean, if whatever you are, in the provider world, being good at understanding the legalities of being able to refuse care or to usurp somebody's rights to give them care.
Yes.
Can get you into a lot of trouble if you're not sure what you're doing. So I think this is a really important topic.
It's super important. It always has been. I mean, refusals have always been a big issue. And it's not just, I think it's important to note that it's not just refusal of transport, right? It's important, and I teach this all the time when I'm going around is, let's say you have a patient that, broke an arm or broke a leg. And I've had numerous times where I've gone to, offered pain medication to a patient. And then once you say fentanyl, like, hey, I'm going to give you some fentanyl, they freak out.
Right.
I don't want fentanyl, right? And they refuse it, right? Well, a huge part, and we'll get to this, a huge part of the whole refusal process is what you document. Mm-hmm. Because at the end of the day, it doesn't really matter what happens on the call or what you said.
Right.
It is what you document happened. That's what's going to be in the court. Yep. That's what's going to be... either saves you or hangs you.
Yeah, documentation you cannot separate documentation from anything we do.
No, it's
if
huge.
You didn't do it, you don't document it.
Didn't document it, you didn't do it. That's exactly right.
Yeah.
So I think it all starts with the patient, whether they're uninformed, but it starts with the patient that's maybe uninformed or maybe uncooperative. They don't want help. Somebody called 911 for them, and then you get there and you're up in their face, doing your thing. And there's lots of ways, and I know, newer paramedics or EMTs, they struggle. They don't know how to deal with this. Like, what do I do, right? Whereas as a more experienced provider, and if you're working on a truck, or maybe you're riding the fire truck that day, right? And you've been doing the job a while and you go on a
Right.
call and you've got a couple of inexperienced EMTs or paramedics on the ambulance, like, and you can tell this patient's being a little bit difficult. Like, you learn those skills over years of a little bit of verbal judo of
Right.
how to go in and talk to a patient,
Right.
and convince them that, hey, we're just here to help you, right? And talk them through, hey, what does that look like? One of the things that I'll always do, like kids, for example, they get freaked out. Everybody hates dealing with kids. I like dealing with kids because they're not trying to manipulate anything. They're super honest.
Pure medicine.
Yes, exactly. They're not trying to, like,
manipulation.
is this guy really hurting? Do I really need to give him pain meds? Or is he just kind of being a big baby? Where a kid will tell you straight up, like, you can tell this is hurting, or no, it's good, I'm good. So...
I do like that about pediatric medicine too. It's there's very little secondary gain with the little kids.
Correct.
And there's a reason for it. You got to really take it seriously.
Yeah.
But back to the refusals, I think that, and obviously the pediatric population is very complicated when it comes to legal refusals.
Oh yeah.
Right. And I get med control calls all the time. In fact, most of my med control calls are for refusals.
Yeah.
And some of these situations are pretty complicated and there's a lot of moving parts, and if you're a new medic trying to navigate through some of these things, you can get in some trouble.
I
if you
remember
don't
being
know
a
what you're
brand
doing.
new paramedic and going on a call with a 15-year-old who didn't want to go to the hospital, and I'm like, what do I do with this? And we called mom and dad. Mom and dad refused on the phone, and I was like, I don't know if we should do this. Is this okay to do, right?
Oh, yeah.
And that's one of those situations where if you're a new provider, you can call the med control,
Yeah.
say, hey, is this okay? Is this not okay? But yeah, dealing with kids. So informed consent, right? They have to be, obviously, first off, they have to have capacity, right?
Correct. Mental capacity. That's right.
Yeah, the patient
yeah.
has to be able to understand or comprehend what's going on.
Yeah, they have to be able to demonstrate that they have the cognitive abilities to be able to understand what they're refusing. If you, which is later on in the process, but part of documenting that there is mental capacity is a patient being able to know where they are, to be able to demonstrate that they can think critically and make decisions for themselves,
Yes.
knowing what the risks and benefits are.
Well, and I think that's part of the initial phase for me is pre-hospitally. If I know right off the bat, oh, this guy's altered.
Yeah.
Like whether he's under the influence or whether he's had a seizure or whether his blood sugar's low, whatever the reason, this guy's altered. I know right off the bat, he can't refuse.
Right.
This guy can't refuse. That's not an option here, right?
Yep.
And like a prime example of patients that we go on that can't refuse.
Yeah.
Somebody that's attempted to harm themselves, right? By law, they cannot refuse, right? And so I'll tell those patients, like, I won't verbal judo them. I'll be very polite about it, but I'll tell them straight up, look, bro, you got two choices. You can ride in the back of the ambulance with me. We'll take a nice, easy ride to the hospital, get you some help, or you're going to ride in the back of the cop car.
Yep.
That's literally your only two choices.
Yep.
I'm not going to, beat around the bush, but since you've attempted to do this thing, and then if that doesn't work, I just bring in PD and then never had an issue.
And that is where your experience as a paramedic really pays dividends in patient care, because you can tell in certain situations where you got to cut to the chase and tell them, hey, listen, two choices here.
I'm not going to spend an hour talking to you because we know what's going to happen here.
But there are situations, though, and that you can't do that, and that you have to be able to be patient and to build this advocacy with the patient relationship to get to a place where they trust you and where they're listening. And that takes time sometimes. We don't have a lot of time. But as an experienced paramedic, you can differentiate, you can see.
Real quick.
Quick. That's good. That's good. And there's certain, like you said, certain no-brainers. It's like, I'm sorry, you're 12. Where are your parents? I'm sorry, I'm taking you.
Exactly.
You're clearly drunk and intoxicated with whatever.
Right. And that gets into some sticky stuff. Like, we've had it where a guy's had a beer or two beers at his house watching a game.
I'm glad you brought that up.
And something happens, and then they get called, 911 gets called. It's like, well, this guy's not really drunk, but he's had two beers. Like, this is where you're kind of getting into that gray area.
You know what? So legally, a patient can give informed consent having ingested alcohol.
Exactly.
right?
Yes.
Even more than you could ingest. Maybe like for you
Right.
might
Everybody's
get a little
different.
intoxicated if you had that much beer, and this patient can drink more beer and maybe have no ill effects.
Right.
If that patient can demonstrate that they have mental capacity, even with alcohol in their system, you have to give them the right to refuse.
Yep.
Now, I'll tell you what, and this is the way I coach up my medics, and we'll talk about the specifics of how to do this, but if that is a situation where alcohol has been ingested and you're about to give them the right to refuse, you better document the heck out of it and what you did.
Absolutely. You know what a lot of departments are doing now, and we've actually discussed this in our department, is videoing the refusal.
Oh, yeah.
They've actually talked about either, and I know there's a department around here that is now, they have to call med control every refusal. They have to call med control, and it has to be audio and video recorded as they're calling them with the patient.
Wow.
So that's
they are high risk.
Yeah, and then that way the patient can't come back, because regardless of what you document, the patient can still come back and dispute it.
Oh, yeah.
Right? So when it's on video or audio recording, it's kind of like a body cam, right? Like, and there's EMS that are wearing body cameras.
Well,
they
there's
can't dispute that. No, go
you
ahead.
can't. There's a famous story of a patient that was in New York, and I think the patient had Lou Gehrig's disease, ALS, was on a respirator, couldn't talk, and daughter called 911 because the ventilator failed and she couldn't find the ambu bag to ventilate dad. So she was actually breathing straight into his
Tube.
His trach.
Yeah.
Daughter.
Yeah.
Face on the
Like
neck.
blowing into it? Oh, wow.
Yep, that's the only thing she could figure out to do.
Oh, man.
And so her and the caregiver, it was like a home health nurse or something like that, they call 911. 911 arrives, and based on what I read, and if you're familiar with the case, I might be wrong on some of the details, it's been a while, but I think the mentality there kind of freaked out a little bit to see what was going on.
Guy with a trach, yeah.
Yeah, and the ventilator failed, and
Get a BDM
and so I think, and then when the lead medic walked in, he's like, well, guys, load and go. Put him on the gurney, took him to the ER, to get him on get him, get
stabilized,
him, whatever.
yeah.
And anyway, they ended up going. They lost in court for kidnapping. What they didn't know is that he could communicate. And he communicated with a program on his computer where he could use his eyes or something to be able to
type or
communicate
whatever.
typing or whatever. And he could have communicated. He could have given consent, or he could have refused if they would have taken the time to determine whether or not he had mental capacity and legal capacity to be able to consent.
Right.
And he could have, and I don't know a lot of the details here, but apparently he didn't want to go, and they took him without asking, and they sued the city of New York or whatever it was, and they won. It was
that seems kind of cheesy.
Yeah, well, it was kidnapping basically is what it was.
But I mean, it sounds like
There's
even though they were
details.
freaking out a little bit, but it sounds like they did the right. I mean, how else is he going to get ventilated if they leave?
Well, they could have given him an ambu bag or something. I don't know.
So.
I mean,
keep bagging him till you figure out.
Well, regardless of the details of that
that's
case,
important about consent. Yep.
Is that you need to
even in that situation where it sounds like they were doing the right thing,
trying to,
they still got the city still got sued.
Yep, or the patient that you document, or you have a patient that can, does have the ability to refuse, and then you allow them to refuse, and then they go into cardiac arrest later and die, and then you come back later on in your shift to the guy that refused.
Yeah.
You better make sure your refusal was
rock solid.
Absolutely.
We've had,
right?
Yeah, absolutely.
Because if you don't document it, you didn't do it. And if we're looking at in the court, we're looking at a refusal that was poorly documented. You could have said the best things. You could have had the perfect refusal, but if you didn't document it, it's not going to look so good from a lawyer's perspective.
Absolutely. So, and that's all they're going to do is look for those holes in your documentation. So, documenting and establishing capacity. Like, is the patient, everybody remembers A&O times 4, right? Are they alert and oriented to first place, time, and event, right?
Is that what you'll ask?
Well, yeah. So typically, I think the standard thing is like, I mean, I'll just gauge it from like, first off,
kind of ask different questions sometimes.
yeah, everybody asks
Who's the
different.
president?
Yeah, who's the president? What day of the week is it? What
Yeah.
city are we in? What month is it? What year is it?
Yeah.
All those kind of things. Like, you can establish, I think, mental capacity by if I come in and if you immediately like, hey, what's going on today? And you're like, man, I started having this chest pain. And then through my assessment of asking you questions, what's your name? My name's Eric. Okay, Eric. My name's Matt. Like, when did this chest pain start? Oh, it started, 2 days ago. Okay.
Yeah.
And they're answering my questions like, I've established capacity with, they can tell me their name, they're obviously interacting appropriately, they're
Right.
giving me good detailed information about the acute problem. Like,
And then you ask for the year, and they say 1847.
yeah, exactly. And then it's like, does Frank have dementia? No. But so, it's important to establish that capacity. If if they're calling for help and they're being transported, right? It's not, you can always put in there like, do you want to go to the hospital?
Yeah.
Right? Yep, I do. Okay. You just consented to be transported by ambulance to the hospital.
Most of the time we have issues. I'm number one on our call list right now. I work with a group of medical directors, so I get first call. Yesterday, I think I had 5 calls, and they were all refusals.
Like, what were they calling you about the refusal?
So one of them was a patient that had called. No, I think a family member had called 911, and I think they were afraid of suicidal ideation. And what was it? It was something I can't remember what the chief complaint was, but the patient was refusing to answer questions.
Okay.
And so the medics called me and said, "Hey, how can I let this person refuse to be transported
Yeah, I can't
when they won't even communicate with me?" And
Legitimate question.
the medic was telling me that when they would ask the questions to ascertain whether or not they had mental capacity, they would just keep repeating, "I'm of sound mind. I can make my own decisions." And that's all they would say. "I'm of sound mind. I can make my own decisions."
That's not enough for me.
No, and so we talked about it, and we had agreed that if they're uncooperative to answer your questions, then we're going to transport them because we can't assess them and we can't determine if they have the mental capacity necessary to make to have informed consent.
Right.
And so I said to the medic, "Go ahead and get them, transport them." And if
Was
they
PD there?
refuse, PD was actually
Okay.
there, and you could just tell the patient, if they really were of sound mind,
Yeah.
they could see the
Listen,
logic.
yeah.
Hey, listen, if you don't want to go, I can't take you if you can help me by answering these questions. But if they refuse and they can't see the logic in that, then they're not of sound mind, and we transport them and let the ER figure it out.
Yeah. Yep. Yeah, and who knows what they were thinking, but maybe they were thinking, oh, I got a lawsuit here. Like, oh, they're going to take me against my will, and I'm going to be able to sue this city or something like that, Well, hate to tell you, but again,
Or money, too.
Better document that very well.
Yeah.
So you've got capacity, as the paramedic, if I have somebody that I've determined has capacity to refuse, they're alert, they're oriented, they're interacting with me well, I'm determining that they have capacity. Now I'm kind of going to step 2, which is now I'm going to inform them of, hey.
Well, I'm so glad you said that, because this is where most of the folks that I talk to on online, med control calls, is they'll say, yeah, they got a refusal here, I got a 45-year-old, blah, 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 blah. They're AN04, GCS 15.
What does that mean?
That's only the first part of, and that's just mental capacity,
Yes.
right?
No.
I mean, I can, the age, and so you kind of get the
Right.
legal capacity there. But what you're about to talk about, though, is something that oftentimes gets missed. And it's actually really the most important part, because the beginning is just determining whether or not they can understand what you're about to tell them.
Exactly. And honestly, I think in reviewing a lot of calls and talking to a lot of paramedics and stuff, I think a lot of providers do this. What they don't do is they don't document it, right? Because it's an extra step in documentation. They're checking all the boxes in their flow charts and stuff. Patient was A&O times 4. Patient GCS was 15. Blah, 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 blah. But then in the narrative, they don't take the extra 5 minutes to say, talk to the patient, inform the patient that I was seeing EKG changes that were indicative of a heart attack. And I informed the patient that he could be having blockage in his coronary arteries, which could cause him, and all the negative outcomes of that. And patient acknowledged what I was saying, that he understood the risks. And I even had it just the other day. I can't remember the nature of the call, but it was a guy that did not want to go to the hospital.
Okay.
He was adamantly not wanting to go, and he needed to go. He was sick. Like, his blood pressure was crappy.
Right.
He was not doing well. And I don't very often say this. I've said it a handful of times in my career, but this was one. And I'll tell people that straight up. I don't beat around the bush. I'll tell them, like, listen, if you didn't need to go to the hospital and you were able to refuse, I would have zero problem not taking you to the hospital. I would have no problem having you sign my report, going back to the fire station, eating some ice cream. Right? You're not in that boat. You need to be seen in an emergency room. You need to have some further testing done. You need to be seen by a physician. And this is why. Your blood pressure's low. Your heart rate's high. Your blood sugar, whatever the case may be. There are things that are off that I'm seeing that are not good.
Yep.
And if I leave here, some bad thing. Oh, that's what it was. It was a fall. That's what it was. A guy that had fell and whacked his head.
Yep.
No LOC, but he was older. He took aspirin. And I was like, you probably ought to go and get checked out because it's very common for a head bleed. It's probably not a big deal, so on and so forth. He did not want to go. And I'll tell you, and this is another hint for our new providers out there, most of our guys, this was an older gentleman, wife was on scene. Of course, what did wife want him to do?
Oh, she wanted him to
Come
go,
on,
for
Eric,
sure.
just go get checked out. And so my angle was, Eric, listen, if you want to get some peace of mind tonight, go to the hospital and make your wife happy. Because if you don't go with me right now, she's going to be nagging you to death for the next 2 hours. And most of the time, sure enough, this guy went to the hospital. He ended up having a subdural head bleed. Small, wasn't anything big, but he did actually end up having a head bleed. So informing them.
And being assertive.
Absolutely.
Oh, he refused. I guess
Okay.
we'll go back to the station.
Have some ice cream. Yeah.
Yeah.
If you're a senior guy or an officer, you need to, whoa.
And I think that's a lot of the value of what education can do and helping to fuel that, or it's almost like a gun, right? It's like it's the ammunition in that gun to be able to deliver the information and knowledge of the possible consequences of a disease process.
Yep.
I mean, you see that really high blood pressure, and you're thinking, man, this guy could blow a gasket.
Stroke out.
I'm going to tell him a little bit about a stroke, or you see that injury pattern on the like I had a refusal actually yesterday. One of them, an older guy, was in a car. I can't remember what he hit. I think he hit a house, and
that's always good.
he wasn't wearing a seatbelt.
Even better.
And he splintered the windshield, hit his head.
Fantastic.
And he was refusing care.
Yeah.
And he was ANO4, GCS 15. We communicated to him all the risks and benefits of transport. And now you don't have to go through every dot and tittle, but you want to tell him there could be a life-threatening condition that could exist in your head or your abdominal or your chest cavity that needs the things that we can't do here. That we need to get you to the hospital to be able to rule out these emergencies.
Yeah.
But he refused. We checked all the boxes with an appropriate refusal. I confirmed it over the phone, talked to the patient, absolutely refusing, and we had to let him refuse.
Yeah.
And we told him, too, well, we may see you later.
And you'll always have that family member, too, that's like, well, can't you guys just take him? And it's like, no, I can't take him against his will. And that's what I'll tell him. Like, I can't kidnap him because that's literally, like you said up in New York, that's literally what it is kidnapping.
Yep.
So, mental capacity, obviously you need to explain the risks. If you feel that what's going on with the patient, they need to get to a higher level of care, whatever the case may be. You need to explain those risks up to and including death. And it's very rare that I'll be like, look, bro, if I leave here...
You could die.
Yeah, you could die. You're not looking very good. Usually when I go that far, the patient's like, okay, I'll go with you. Yeah, I've never had somebody be like, nope, I'm willing to die right here. So, mental capacity, inform them of the dangers. Obviously, there's lots of different ways to call med control. Like in my department, I don't have to call med control. Obviously, if it's one of those weird situations like that where I feel like, man, this dude needs to go, and they're adamant about not going, that's when I would be like, okay, now I'm going to call like, hey, I'm going to let you talk to a physician. And maybe if he, because that's just a cover in my butt even more of getting in trouble, litigation.
I think this is the way that I train my medics to do this, and we've talked about this in some of our lectures we've made together. But I use the acronym for a great band, ACDC. And so when I document, and I have my medics document, and I did this in my own charts, for patients I saw in the ER, is I would say the patient is able to make an autonomous decision. They can make a decision on their own. They have decision-making capacity. You can word it any way you want. I like to use the word autonomous because that's the A for ACDC.
Right.
And then the C would be consent.
Yep.
Is there mental capacity and legal capacity?
Yep.
And so I'll document the next sentence might say something about how they're A804 GCS 15 and the age of the patient and they've got legal and mental capacity. But I go further than that, and I'll document quotes.
Yep.
This patient is having abdominal pain, for example, and they're refusing care. And I ask them why, and they tell me that they had a splenectomy not too long ago. The hospital bills, they're still paying them off, and they felt like the doctors weren't listening to them, and because of the cost of everything, they are going to refuse care. Mm-hmm. So this patient's talking about the fact he has abdominal pain and knows right away it could be a surgical emergency when he talks about a splenectomy.
Yeah.
And then he talks about the fact they're still paying the bills. I quote them.
Yeah.
And I put that quote into my medical decision making.
Sure.
And we should do that too.
Absolutely.
So this patient can make an autonomous decision. I document the legal and mental capacity. Now that's only half of the job. The other half, you covered it, is the DC part. So AC we're covered. Autonomous decisions can only be made by people who have legal and mental capacity.
Yep.
And then a disclosure is the D, ACD, disclosure. Yep. And we have to be really good at pulling up that knowledge we've learned from watching our videos and from learning from your medical director and CEs and educational activities you're training. I know that when I see this injury pattern, it could mean badness. Yeah. And so I'm going to disclose that information to my patient. And I'm going to document that I disclosed it. And I'm going to document that I said there's a potential life-threatening situation going on that I cannot detect here. We need to get you to the ER where they can do more. Yep. I'll document that disclosure of information. That's super important. Yep. Now, you don't have to document every tiny little detail. And the patient, died of a ruptured spleen, but you didn't talk about the spleen, so then you get sued. That's not the case. A life-threatening condition because of the abdominal pain. There could be a surgical emergency that we can't see here. You could be bleeding right now. We wouldn't know it. Right. Those are the types of conversations you want to have, and that knowledge of patterns of the vital signs. Mm-hmm. We talked about high blood pressure, low blood pressure. We could talk all day about what to disclose, but it's not just the risks, it's also the benefits. Yep. Right? So the risks and benefits, the risks of refusing and the benefits of letting us transport you. Yep. And oftentimes that information that the patient might say, oh my gosh, I didn't know that.
Yes.
I mean, I'm not telling you that, but I'm thinking it.
Right.
Okay, all right, I'll be transported.
Yeah. Right? And most of the time you can usually talk them in. That's the good part.
But we're not done. ACDC. The last C is the patient has to be able to communicate this back to you. Mm-hmm. Because if you go through all the disclosure and they don't understand it, how do you know they understood it? Well, they need to communicate it back. Sir, we've talked about a lot of things here. I need you to tell me why or how. Are you still wanting to refuse? What do you think about all the things I just told you? Yeah. And they can, I understand that there could be a surgical emergency here because of my abdominal pain. I know I was just in a bad car accident and I wasn't wearing a seatbelt. I understand that there could be a life-threatening situation that could kill me, but I absolutely cannot miss this meeting. I need to go.
Yep.
Right? Yep. I mean, document that decision, that
in
communication.
Yeah.
Right, exactly. So I think ACDC is a good thing to remember. I actually think about that acronym and I put them into my note and I document all those components. And
it keeps track of the questions you need to ask and the documentation you need to do. Yeah.
Super important. So many refusals in such a high-risk situation.
Yep. Yeah, not only for the patient, but also for litigation reasons from our standpoint. So. Yeah, and that's that final thing is that documentation like we've talked about. But super important that you know your policies and procedures with your agency. Some agencies require you to call med control for refusals, but it's very important to go through that and do it right.
It is so important.
Good topic.
Be safe out there.
Thank you for listening to EMS, the Erik and Matt Show.